Kathleen already did the hard part, talking about the clinical aspects of this, and now we go to imaging. So, of course, this needs a disclaimer, since ultrasound is the cornerstone of this assessment, either transvaginal or transabdominal, but it always starts there. So, when should we consider cross-sectional imaging then? Well, if you have a suspected case of deep vein obstruction, I think that you need cross-sectional imaging to get a complete overview of the disease, to understand what you are going to be treating or not. If you have an inconclusive duplex ultrasound examination but a high clinical suspicion, you need cross-sectional imaging. In case of extensive deep vein thrombosis, which are a little bit outside of this talk, but then you also should be considering cross-sectional imaging to assess the complete disease. And in your pre-interventional workup, it's very valuable to have a good anatomical overview to decide on your approaches, the tools you're going to need, and what you might omit when you do only 2D venography. So in patients with fast recurrent disease that have been referred from primary care or phlebology clinics that have fast recurring disease or a clear combination of leg disease and pelvic symptoms, those should be evaluated in addition to the duplex ultrasound with cross-sectional imaging. And sometimes if you have a tertiary referral for counseling, I think you should complete your imaging workup with cross-sectional imaging. So in short, pretty much always when you have a true PEVD, you're going to need cross-sectional imaging. Options, this is of course easy for us radiologists, so either CT or MR. Ideally, you're still working with a large amount of patients which are in their fertile age, so if MR is an option, do the effort of getting a right protocol, get your technicians trained and make sure you understand MR and focus on learning that skill before you start treating these patients. Important parts to assess, there was already mentioned based on the SVP classification, of course, nutcracker, the ovarian and spermatic vein insufficiency, May-Turner, the non-thrombotic iliac vein lesions or deep vein obstruction, pelvic venous plexuses, which are a large combination of parts in the pelvis that communicate, and signs of collateralization. So for the nutcracker, clinically, this needs to be something that is suspect, not to be based on imaging alone. If you have your chronic flank pain, hematuria, and abnormal kidney function, then maybe imaging signs are vital to diagnosing this correctly. We look for the compression, the collateral formation in the hilus, and dynamic alterations of a pelvic shift, for example. And this is an example of such a pelvic shift. What you see here is the enlargement of the left ovarian vein, fluxes across the pelvis in the uterine plexus and then back up to the right side. And it can be pathognomonic in the case of a true nutcracker. The ovarian or spermatic vein insufficiency, most mentioned in the literature, of course, is diameter. Reversal of flow is at least as important, and caliber, if it's not really enlarged, can still mean that there is an insufficiency. Look for these reversal of flow signs on your dynamic imaging. Look for the prominent appearance of the plexus of the distal part of the ovarian vein, which can be also a hint. And of course, the enlargement of engorgement of the veins around the ovarian, the ovary. Same in spermatic vein. So dynamically, this looks like this. Turn off the laser pointer. Not work? No. Yeah. So this is dynamic MR acquisition. You see the reversal of flow in the ovarian vein, the enlargement, engorgement here around the ovaries and towards the uterine plexus. Here as well around the internal pudendal vein and next to the vagina and the vaginal plexus. As a side note, this here is insufficiency of the superficial system. So this is the saphenous vein junction that's insufficient. But these kind of patterns with reversal of flow and stagnant flow at the level of the plexus are typical for pelvic venous disorders. So May-Turner and the non-thrombotic iliac vein lesions, often diagnosed in healthy patients on CT, but it's of no use to look for this in healthy patients. It's only of value in patients that are clinically diseased and suspicious of having venous obstruction. So you see often these web formations, and also here on MR you can see the same webs. And if you then make the venography, you will see both these webs beautifully on the 2D venography, but as well the collaterals along the spine, and here into the presacral plexus. If you have a more extensive disease, and there's also a case of post-thrombotic disease, you can see more collaterals here at the rim of the pudendal vein and the pubic bone, and here at the obturator loge, and these are also collaterals that descend through the pelvis to the backside. There are some new developments which are interesting because we're always looking for ways to quantify the image findings with the disease that we see clinically. This is a study that looked at the 3D image of the iliac veins, looked for the degree of stenosis based on these images, and then performed a flow rate assessment to see if there was a decrease in flow rate. And what they found was that there was actually a nice correlation, or at least a potential correlation, between the degree of stenosis, the decrease of the flow rate, and the effect of treating these patients endovascularly. If you had both more than 50% stenosis and evident decrease of the flow rate, treating the stenosis was most effective in these patients. Then, when we look at the venous plexus, a very complex network of parts that consist of the uterine, the vagina, the pelvic floor, the pudendal veins that are right behind the pubic bone here, and these branches descending into the pelvis, through the pelvic floor to the major labia majora. If you look at this with phlebography and you inject selectively into the pudendal vein, you often see an enlargement of that plexus, with also a communication here towards the vaginal branches, and sometimes into the labia majora from behind the pubic bone. So, to sum things up in Dutch, let's not depend on one exam and look at these patients from a multidisciplinary perspective. Use your duplex ultrasound and your cross-sectional imaging to make the right decision. It's easy to compare cross-sectional imaging in time. If you, with your duplex ultrasound, haven't looked at a certain aspect of the disease in the beginning, you will have to go back and try to reproduce it. On cross-sectional imaging, you have this at your disposal at all times. It will absolutely help you to save procedure time and fluoroscopy time, which means shorter procedures, less complications, and less radiation, which means better safety, not only for the patient, but also for your staff. Thank you for your attention.